All right, the Committee on Health and Human Services will come to order. We do have a quorum present. Representative Pinto moves approval of the minutes from April 18th, 2018. All those in favor of adoption of the minutes from April 18th, 2018, please say aye.
Aye.
All right, those opposed, no. The minutes are adopted. First item on the agenda for today is House File 3196. I'll move to take House File 3196 off the table. Any discussion to this motion? All those in favor of the motion, please say aye. Those opposed, no. The motion prevails. The bill is before us. I'll move House File 3196 be re-referred to the General Register. All those in favor, please say aye. Those opposed, no. Motion prevails. House File 3196 is re-referred to the General Register. Thank you. The next bill that we have will be 3138. And I will move House File 3138 to be re-referred to the Committee on Ways and Means. We have the bill before us, and first up, I'm going to move the A18-0776 amendment. This is the HHS Omnibus bill, and I'll just walk through the amendment. It has several pieces. This is the author's amendment to the bill. This is the 18-1. And there's several substantive pieces to this author's amendment, and I'll just go through them. And these are in the order of the bill. So line 1.4, it's a rare disease council. This provision adds dentists to the rare disease council. That was a provision that was brought forward by two members that were interested in that. I think that's a good idea. Fairly minor change. Lines 1.7 to 2.3. This is the governor's language regarding non-emergency medical transportation. Allows DHS to audit NEMT, allows DHS to terminate NEMT providers if they're not eligible. The lines 2.5 to 4.17 in the author's amendment are the direct contracting proposal that we heard, I believe, I guess it was Monday, I was going to think it was last week, in this committee. So that's that bill. Lines 4.18 to 9.17 is a provision that we passed in last year's bill that requires enrollee verification for public employee or public enrollees for public plans. Lines 9.9 through 11.2 are the mental health and substance use disorder parity work group. 11.16 to 12.8 is the governor's proposal for an assessment tool for alcohol and substance use disorder and approval for initial set of services. I think it's a pretty common sense proposal and seems to work functionally. 12.12 to 15.14 allows counties to appeal regarding clients that no longer meet the medical criteria for a state-operated facility. 15.16 to 15.30 is a minor change from the sheriff's. This will allow alternative methods for drug disposal programs that they currently use. Collection receptacles, and many are using alternate methods of disposal, which many sheriffs are moving towards, and they would like the flexibility around that. That's that provision. 16.15 are the riders for mental health and substance use disorder parity work group. 16.26 to 17.7 is rider for IT cost technology upgrades for the Office of Health Facility Complaints. Those are the sections in the bills that those are attached to in the A18-1 amendment. And so I would entertain questions and discussion to the author's amendment. Seeing none, all those in favor of adoption of the amendment, please say aye.
Aye.
Those opposed, no. the A18-1 is adopted. All right. We also have several committee amendments that members have in their packets, and we will take those amendments one at a time. I would suggest that there's I think 30, how many amendments? 33, and I think most of those are from the Republican members, so.
Sorry.
So I want to point that out. I don't guilty as charged, I guess. So we'll go through those, and many of these have been bills that we have heard and should be familiar with. Some are not, that have been through this committee this time. So they may be newer to members and may require a little newer, different discussion. But we'll take them one at a time. And if we need to, we can come back this evening to finish amendments. But it's my intention to complete the bill today. With that, Representative Murphy.
Mr. Chair, and I was just looking at the handouts that we have, and we have two spreadsheets. And I understand one was the spreadsheet that reflected the author's amendment. Is that correct?
That is correct.
And I'm wondering if you can help me understand which one is which. The one that was in our packet, I suppose.
I'm sorry. Mr. Berg, can you walk through which one's which?
Mr. Chair, members, it probably should be more prominent. In the upper right-hand corner, you'll see one is labeled 2018 Session House Budget Tracking, HF 3138 DE Authors Amendment. It's in very small type. That's now the current spreadsheet.
Thank you, Mr. Berg.
Thank you.
All right. All right. Members, the first amendment in the packet is an amendment that was brought to me by Representative Green for a situation in his district. I'm sorry, the A18-0808 amendment. I will move the A18-0808 amendment. The amendments before us, and this amendment is from Representative Green. It's a situation in his district where a camping facility has to provide sanitary disposal on site. They can't do that because of because of the sanitary dumping station on site doesn't work for recreational camping because of the proximity of it. An alternative dumping station is available, and this is camping, and RVs are something that we do cover in this committee and sometimes talk about whether that's the fair or local campgrounds and so forth. So that's was brought to us by Representative Green. It's a local situation, and it seems to make some sense. So that's why I'm offering the A18 amendment. Questions to the A18-0808? Representative Pinto.
Thank you, Mr. Chair. I guess I'm picking up that maybe this has not had a hearing anyplace, and I wonder if we could just get any comment from the Department of Health. It does sound like a local situation. I just want to make sure that we get any input that they may have.
All right. If the Department of Health might be here. Welcome to the committee. Please introduce yourself, and if you had an opinion about this particular situation or any knowledge of the situation up in, I think, Monoman or Hubbard County.
Hubbard County. Thank you. Good afternoon, Mr. Chair, members of the committee. My name is Stephen Diaz. I'm the Acting Assistant Division Director for the Environmental Health Division for the Minnesota Department of Health. The department is concerned about the language in this bill, and we would prefer to continue to work with the operators regarding this particular issue. As you are all well aware, that wastewater from any type of facility, including RVs, can contain hazardous chemicals as well as hazardous biological agents. And so we would prefer to kind of continue working with the operators to find a positive and useful solution.
All right, thank you. Representative Pinto?
I guess that's all. Thank you, Mr. Chair.
Sounds like a no.
Nice to meet you, Mr. Chair.
All right, other questions? Representative Liebling?
Thanks, Mr. Chair, and just, more a comment, when you look at the amendment, notwithstanding any law or rule to the contrary, Commissioner of Health shall provide a variance. It seems to me this is, for something that didn't even get a hearing, this is really a dangerous road to go down. It just takes and substitutes what is essentially a political process for a scientific process. I think it's really troubling, and as you know, right now, the issue of clean water is kind of a hot topic. I just would have real concern about this. I mean, if it's unreasonable to restrict them in this way, I would hope that the Department of Health would work with them, but I'm just very uncomfortable going down this road, notwithstanding that a member wants to. That kind of process will definitely come back to bite us, I think.
All right. Further discussion? From what I understand from the representative, this has been something that came up fairly recently and was unavailable or to jump into the process, and it's kind of reacting to a situation in time. Would take the concerns under advisement, but I would like to try to move this forward. So all those in favor of adoption of the amendment, please say aye. Aye. Those opposed?
No.
The amendment is adopted.
Division?
Division having been requested, all those in favor of adoption of the A18-0808, please raise your hand. Those opposed? There being 11 ayes and 7 noes, the amendment is adopted. All right. All right, let's move to the A9 amendment. Representative Albright.
Thank you, Mr. Chair. Members, I had drafted the A9 amendment because I thought DHS was moving a bit too fast with the next generation IHP. While I'm pleased the department has moved the process back for 1 year, allowing for more time with legislative and community, to provide for more legislative and community input, we need support efforts that bend the cost curve in medical assistance, like the IHP program is doing, but we also need to continue to think creatively about how we save money to the state in our public programs. We've been trying, obviously, to move away from a system that pays just on utilization. The more a provider does, the more a provider gets paid, and support efforts that move, in my opinion, to our value-based payment model. I just want to make sure that I go on the record that the department should be doing a better job of involving the legislative branch in that payment reform effort. And at this time, I'm withdrawing the A9 amendment.
The A9 amendment is withdrawn. And we'll go to the A10 amendment, which is Representative Albright as well.
Mr. Chair, members, the A10 amendment allows for the legislative approval of a single formulary. While there might be some concern about this one, I do feel that this is worth consideration as we move the omnibus bill forward.
Discussion to the A10, Representative Pinto.
Thank you, Mr. Chair. I guess I'm going to make the same request, which would be to have a comment from the department on the amendment.
Is there somebody who would like to offer an opinion, DHS? Welcome to the committee, Ms. Marquardt.
Thank you. Thank you, Mr. Chair. My name is Julie Marquardt. I'm the Director of Purchasing and Service Delivery at DHS. I'm not quite sure what comment you're looking for, other than if you're looking for the reaction of why we were proposing what we're proposing. I'm happy to comment on that.
Ms. Marquardt, if you could just, perhaps, if you're familiar with the A10, if somebody, I don't know if you have it in front of you.
I do.
If you could just maybe walk through the department's position on the changes, I would say probably focusing on page 5, bottom of page 5.
Okay. So, Mr. Chair, I think if I'm understanding the amendment correctly, it would require us, before going through with a single preferred drug list, to do a study and then come back to the legislature and receiving explicit authorization before implementing that. I will say that the reason that we were proceeding with it was maybe not necessarily the kind of study that's outlined here, but I will say we've been looking at our drug costs for a number of years within our managed care contracts. And there is a stark difference between the drug trend we see in fee-for-service when DHS manages the drug benefit, which is relatively flat, and the amount that we are having to increase the managed care rates year over year associated with increasing drug costs. We have tried a number of different alternatives. We've tried to manage, we did this with the hepatitis C drugs when the concern around rising costs occurred in that particular category, and we did see success with that. We have analyzed this with our drug rebate manufacturers, with the vendors that help us manage our preferred drug list, as well as our actuary who helps us develop our managed care rates. And while we didn't propose this as a savings measure, there actually is cost savings to the state based on the analysis that was done. And we really didn't do it until we did the public comment period for the next generation IHP. And that was a lot of public engagement, a lot of different groups. And overwhelmingly, that was one of the things that we heard back consistently was the disruption for enrollees when they changed managed care plans or when they move off of managed care into fee-for-service. That disruption and that lack of continuity was of concern for everybody. And I think, frankly, the only people who we didn't hear that supported it were the managed care organizations themselves. So while we may not have done maybe exactly what's listed here, I think we did kind of reach the spirit of what's written here. And that's why we're moving forward with, or proposing to move forward with it.
Representative Pinto.
Thank you, Mr. Chair. So Ms. Marquardt, as I look at this, the idea of having to come, I understand the complying with the spirit of it, but the letter of this is that you'd have to come and get approval in the form of enacted legislation in the couple months that we meet each year, the legislature does. That seems to me that it could be pretty cumbersome and prevent some needed changes, but you know your business much better than I do. Can you just comment on how that might work for what you're attempting to do?
Ms.
Yes,
Marquardt.
Mr. Chair, I do, if we were to have to proceed with going back and meeting precisely what is written here, engaging these parties, coming back with a report, coming back with potential legislation, assuming that would not occur until next legislative session, I don't think we could proceed with the next procurement in the way that we have contemplated it. We would have, and I think it really undermines how the integrated health partnerships can operate. I think it loses a piece of that consistency and continuity. So if we had to do that, I don't believe we could proceed with what we have put forward as doing this as a July mid-year change to our contracts. We would have to wait until such time And then that may change the procurement timeline. It may change the parties that may be able to respond to that procurement. We would have to evaluate all of that.
I have a question for another testifier, or to ask someone else, but I see our colleague has a hand, Mr. Chair, so whatever.
Representative Halverson.
Thank you, Mr. Chair. And for Ms. Marquardt, I'm curious, and let me preface this by saying we continue to try to bend the cost curve through various payment models and those kinds of things Representative Albright mentioned. But what we have found through research is one of the reasons that healthcare is so expensive is that healthcare is so expensive. And you mentioned the Hep C drug, and I'm wondering if you would give us a little bit of background about what drove the department to take action with regard to the treatments for hepatitis C, because if I'm remembering correctly, there was a drug that was introduced to the market that was prohibitively expensive, not only for individuals, but for any third-party payer, be it government or private health insurance. Can you walk us through a little bit about what you did to change that and what you're defining as success with paying for that drug?
Ms. Marquardt.
Mr. Chair, so when we began looking at the cost implications of the new drugs entering into the market for treatment of hepatitis C, we initially started working with the health plans on just tracking that, looking at what was happening. We worked through our, we have a pharmacy work group that looks at prescribing and coverage, and the health plans participate on that. We tried to work through, let's create some common utilization management guidelines that we all can use, that the plans could go back to their shops or through their PBMs, try to create this consistency in let's prefer the drugs that have this efficacy for these patient groups, but they are the most cost effective, and all things being equal, the treatments end up with the same result. Let's prefer the lower cost alternative. And we made some ground with that, but there was yet more to do. And so I think we just never quite got what we needed. And recognizing that, we're managing a Medicaid-only benefit, they're managing Medicaid enrollees, commercial insurances, there's a wide group that they are operating with. And so to make sure that the Medicaid program was getting all the value out of that prescribing, out of ensuring that the prescribing practices and the utilization management was being done consistently, we made the move finally. But it took us well over 2 years of just watching what was happening. We didn't do it quickly or recklessly. It was really over a period of time where we just were not getting the results we could see on the fee-for-service side.
Mr. Chair, with regard to the hepatitis C treatments, is that the treatment that essentially can be curative? Do your patients stop taking that drug if you pick the right drug and go through the proper protocols?
Ms. Marquardt.
Do we get to that point?
So, Mr. Chair, yeah, so it is meant to cure, but a lot of the prescribing and a lot of the utilization is choosing patients who are far less likely to be reinfected, because you can get reinfected. So that's a big component of this is patient selection and knowing when to treat. At what stage of the disease are they still engaging in IV drug use, things like that.
Mr. Chair, I think this is really a good demonstration of why we have to be thoughtful about when the legislature gets involved with making those care decisions, because it sounds like there was a lot of background study that had to go into making these kinds of care decisions, and to have to loop the legislature through on those deep dive decision-making, it sounds like it could really slow up the process and the timing when you think about when a new drug gets introduced, when we find out what the cost implications are. And what we're finding is not only new drugs, but existing drugs that have been around for generations are increasing in cost, dramatically by hundreds of percents, by 1,000%. And so being able to manage patient care from the legislature seems like we could maybe get in the way more than we could be helpful. I'm not going to put those words in your mouth because you would never say that to your legislators, but I'm hearing that, I guess.
Representative Loeffler.
Well, thank you, Mr. Chair, and members, I have heard of in my area, which is blessed to have choices in health plans for people on the managed care programs, that they have changed health plans because that's their right when something is dropped from the formula and they want to stay with the same drug because they've got confidence in it and they can find out another health plan covers that. And I also know of personal stories of constituents who are pretty fragile with their health. One ended up being hospitalized and because of a changed drug regimen, and ended up going through a couple of months of really difficult to deal with changes. And so we know we have some really fragile people, and I'm wondering if, Ms. Marquardt, if you could talk to us about if we're going to have one single formulary, what do you envision, or do you envision having an exceptions process, an appeals process, for people who we're all just a unique chemical soup, and what may work for 95% may not work for 5% and may be devastating. And can those 5% ask for an exception? Is there an appeals process to access something that isn't on your standard formulary?
Ms. Marquardt.
Mr. Chair, yeah, the answer is yes. I mean, the short answer is yes. There's absolutely exception processes. To be clear, and the health plans have them, we have them. DHS in its fee-for-service program has to cover all drugs. But we can prefer drugs that are similar efficacy, lower cost. So that's the process we do. That doesn't mean that nobody ever gets those other drugs, and that's never the intent. So where someone does have a clinical reason to have an alternative drug, that can be approved. If the medical necessity is there to do so, it will. I also wanted to point out that the transition for this is long. We intend for this to be a very thoughtful transition, because when you move to the preferred drug list, there needs to be a lot of engagement between us and the health plans. We need to know better what people on managed care, the drug complements that they're taking, and is that going to change how we manage the preferred drug list? So we need to take into consideration everybody's needs. Right now, the preferred drug list, by and large, represents the fee-for-service population. We don't expect that we're just going to take the fee-for-service drug list and apply it to managed care. We have to do a thoughtful job of looking at what are the needs of that population and how do we make that preferred drug list, and then allow the transitions and the exception processes to come into place before people are asked to switch.
Representative Loeffler.
Thank you, Mr. Chair. That was a great answer.
Thank you, Representative. Thank you, Ms. Marquardt. Representative Pinto, you had another question?
I did, Mr. Chair. I just wanted to see if we could get a comment on this amendment from the national, from NAMI, perhaps Ms. Abderholden.
Ms. Abderholden. Welcome to the committee, Ms. Abderholden.
Hi, Mr. Chairman, members, Sue Abderholden, NAMI, Minnesota. What I can tell you is that the Mental Health Legislative Network actually looked at whether there should be one list or not, preferred drug list. And, what we have heard is that, especially when managed care plans change for, the counties and things like that, that people did then have to change their medications because there's different formularies. And it can be kind of difficult to figure out. And so, we certainly thought that one formulary would be great for people as they kind of move and when the contracts change. Whether this would inhibit the department or anything like that, I haven't really spent a lot of time thinking about that, but I just wanted you to know when they did reach out to see what people thought about having a preferred drug list, Mental Health Legislative Network, most of the members really felt like that was a great idea.
Representative Liebling.
So, thank you, Mr. Chair, and this isn't a question for Ms. Abderholden. I just wanted to kind of make a comment on this. So, the thrust of the amendment is to stop DHS from moving forward on this without legislative approval. And I just want to flag for members what we're talking about here. We spent quite a bit of time in this committee talking about PBMs, pharmacy benefit managers, and how they make life difficult for patients. And so what we have now in our medical assistance program, you've heard me talk about this many times, we have this PMAP program, prepaid medical assistance. So we take our public program, we contract with all these HMOs, and then each HMO is contracting with a PBM. And so a patient who goes on medical assistance is subject to whatever that PBM is deciding under that contract with that HMO, which is under a contract with DHS. And so what DHS is proposing is to pull out the pharmacy benefit and manage it in a unified way for patients who are all on our MA program. And you just heard Ms. Marquardt say this is going to save some money, but also it's going to make life simpler for everybody, because it's already, we have this problem when you need a drug and you have and somebody denies you. But if you then are subject to all these different, every time you're on a different program, or we know that they can change the drugs they authorize at any time. And we also know, we've learned through a lot of discussion we've had here, that there's a lot of money that is being made by these PBMs, lots and lots of it. And that's money that we are paying through our medical assistance program to whatever PBMs are being hired by these HMOs who are being paid by us. So I think this amendment absolutely goes the wrong way. We should be looking for ways to get all this administrative, if you will, profit skimming, which is a very pejorative way to say it, but this is all money that the public is paying for people on these programs, and there's a lot of profit being taken out of this because we've got these multiple players handling all of these things. So I think this amendment goes in absolutely the wrong direction. If DHS can simplify this for people who are, after all on the same health program, then that's what we ought to do. And if there's a problem, with allowing or denying some specific drug, I think Ms. Marquardt explained pretty well that there will be a process for that. But we got to get some of the profit out of this, too. There's just no reason for us to be funneling this through all these PBMs when we don't have to be. Thank you.
Thank you. Further discussion? Representative Pinto.
Thank you, Mr. Chair. And so I guess, and that was really helpful, Representative Liebling, and to the two folks who testified. And I guess it really jumped out at me, building on what Representative Liebling said, that that Ms. Marquardt said, the only opponents to this are the managed care organizations. And it does seem like it makes a heck of a lot of sense. And if we feel that there are specific concerns about something that the department is doing in this area, then we address that. But the idea of this cumbersome process where there's the study, but then we require they come back and get the specific approval with this seems to me to not make a lot of sense. So thank you, Representative Liebling, for clarifying my thinking into the two testifiers as well. Thank you, Mr. Chair.
Thank you, Representative Pinto. Further discussion to the A10 amendment? Seeing no further discussion, all those in favor of adoption of the A10 amendment, please say aye.
Aye.
Those opposed, no. No. The A10 amendment is adopted. All right. Division having been requested, all those in favor of adoption of the A10 amendment, please raise your hands. And those opposed? There being 9 yeses and 10 noes, the amendment is adopted. Or, excuse me, I'm sorry.
Wait just a minute.
Count again. All right, count it again. All those in favor, please raise your hands. You could do two of these, please. And those opposed? There being 9 yeses and 8 noes, the amendment is adopted. Sorry about that. All right, next up, we have the A12 amendment from Representative Pinto. Representative Pinto moves the A12 amendment.
I do, Mr. Chair. Members, should I go to the amendment, Mr. Chair? Speak to it?
Yeah.
Okay. Members, the A12 amendment embodies a bill that was introduced by Representative Crecia, and this really is much on his behalf. I'm a co-author on the bill. The provision provides some additional flexibility for grant funds for home visiting programs. In the current grants, all the grant funds have to be used for evidence-based home visiting programs. What the amendment would do, and what the bill does, is to provide a little more flexibility to allow up to 25% of the grant funds to be used for other targeted home visiting programs. As members know, Representative Crecia in particular has focused a lot of work on the child protection area, and home visiting programs can make a huge difference in that area. And in particular, programs that are not evidence-based but are certainly evidence-informed tend to be programs that are working with families that are particularly at risk. The bill contained both policy provision and funding. The amendment simply is policy provision only, and so in that way it may have been an oversight in not being in the omnibus bill, and that it's simply the policy change and that flexibility and not seeking funding. Thank you, Mr. Chair.
Thank you, Representative Pinto. Is there discussion to the A12 amendment? Seeing no discussion, all those in favor of adoption of the A12 amendment, please say aye. Aye. Those opposed, no. The A12 amendment is adopted. All right. Representative Zerwas has the A13-1 amendment. Representative Zerwas moves the A13. Representative Zerwas.
Thank you, Mr. Chair. Thank you, members. After some feedback from the State Ambulance Medical Directors Group, they requested the following language be added to the original bill that was adopted around the adrenal insufficiency bill that was heard and contained in the chair's amendment. They wanted other diagnosed rare diseases added to the bill to make sure the rules adopted covered all patients in emergency situations, and also to change the word standard to guidelines to align with current ambulance definitions. Representative Johnson, the bill's original author, agrees with these changes, and Buck McAlpin from the Ambulance Association is here if members have questions.
All right, thank you, Representative Zerwas. Are there questions to the A13-1 amendment? Representative Halverson.
Thank you, Mr. Chair. No questions, but I think that this is a really good move, and really thank Representative Zerwas for bringing it forward, and the Ambulance Association for working with this to make sure that everybody gets the care they need in emergency situations.
Thank you. Further discussion? All those in favor of adoption of the A13-1 amendment, please say aye. Aye. Those opposed, no. The A13 is adopted. Representative Zerwas moves the A21 amendment. Representative Zerwas, to your amendment.
Thank you, Mr. Chair. Thank you, members. The A21 amendment was brought by the Board of Dentistry. It creates an emeritus active and inactive license. This does two big things. It addresses the idea of allowing someone that is retiring from the profession but wants to continue doing some charitable care practice to be licensed in a capacity to do that. And then under the emeritus inactive license, it's a way to show that a dental practitioner that is no longer going to pay and keep up on their CEUs and stay licensed can have a different status than a revoked license. It's kind of a retired license, if you will. And so the board brought it, and I haven't heard any concerns brought forward.
All right, discussion. Is there anybody from the board who's here? Dental board? Not seeing them. All right. Questions for the amendment author? All those in favor of adoption of the A21, please say aye.
Aye.
Those opposed? The A21 is adopted. All right, the A17 amendment is withdrawn. All right, next up, we have the A19 amendment, and that is Representative Hamilton. Representative Hamilton moves the A19. Representative Hamilton.
Thank you, Mr. Chairman. Members, this is House File 3196, Representative Fenton's bill. We just passed this out of committee this morning. It establishes, or this afternoon, excuse me, it establishes step therapy protocols, and I ask for your support.
Thank you. This is the step therapy bill, the A19. Are there questions for Representative Hamilton on the A19? Seeing no questions, all those in favor of adoption of the A19 amendment, please say aye.
Aye.
Those opposed, no. The A19 is adopted. Next up, we have the A23 amendment. Representative Johnson moves the A23 amendment. Representative Johnson, to your amendment.
This was brought to me by the stakeholders. It's some clarifications on a couple of things and lining things up with the Senate bills. They believe it's important enough to do that so they can make sure this gets through this year.
All right. Are there questions for Representative Johnson in the A23 amendment? Representative Pinto.
Thank you, Mr. Chair. And maybe in this context, I'll say, Chair Johnson, am I right that this is this is also in a bill that passed through the Public Safety Committee? I'm just trying to remember if this is if we had seen this language in that committee.
Representative Johnson, if you could give a little history of the
It's a bill that we heard in public safety, but it was not included in the bill because the funding is through this area and the licensing.
Okay. All right. Thank you. Thank you, Mr. Chair.
All right. Further questions for Representative Johnson in the A23 amendment? Representative Liebling.
Thank you, Mr. Chair. Just want to clarify, Representative Johnson, is this is the same bill that we heard in this committee with no changes?
This is the same bill, just some of the things that the Senate had put in, and the stakeholders wanted that because they feel it's important enough. They want to make sure it goes through.
So, Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair. So, Representative Johnson, if it's different than what came through this committee, could you point out what those differences are?
Representative Johnson.
Give me a moment and I will find it in here.
Ms. Clarkfest, I don't know if you had drafted the difference amendment, if you had oh, I see somebody coming forward. Welcome to the committee.
I'm Teresa Parrington. I'm the Environmental Health Supervisor for the X-ray program, and I'm here to answer any questions you may have
All right.
from the department.
Thank you. And Ms. Clarkfest, did you come up with the differences between what passed out and what came back with the amendment?
Mr. Chair and members, I'm looking for the language in the delete everything right now. I know that this is the language of the Senate file, the third engrossment, and some of the changes that they made were organizational. They moved the definition of security screening system to the proper place. And they limited, they gave the Commissioner of Health a limited time to adopt rules. Those are the differences I'm aware of.
All right, and to the testifier, Ms. Purrington, does that match up with your recollection?
Mr. Chair, committee members, yes.
All right.
Right.
Further questions? Representative Liebling.
Thank you, Mr. Chair, and to the testifier. So does the department have any problem with this version of the language?
Ms. Purrington.
Mr. Chair, committee members, MDH provided technical assistance with the proposed language with the Minnesota Sheriff Association.
So, Mr.
Representative Liebling.
Thank you, Mr. Chair. So I take that to mean that the department, while not supporting this, is not opposed to it either. Is that right?
Ms. Purrington.
Correct.
Thank you, Mr. Chair.
All right, thank you. Further questions for Representative Johnson on the 823? Seeing no further questions, all those in favor of adoption of the 823 amendment, please say aye.
Aye.
Those opposed, no. The 823 is adopted. Representative Lunan, the 824 amendment.
Thank you, Mr. Chairman. This amendment
Move the
pertains.
824.
This pertains to emergency medical services, basically in situations where the consumer cannot shop. I have had conversations with all three parties on this. The plans don't like it, the medical providers don't like it, and the consumers love it, the people that ultimately end up paying for all of this stuff. What this plan does is it's a situation where you have an emergency medical event, and obviously you're not precluded to go ahead and shop, and you receive medical treatment. It forbids the medical provider from balance billing. In other words, anything the insurance carrier won't pay then gets handed over to the consumer or the patient. The big thing is it requires health carriers and medical providers to negotiate, to come to the table to determine what is reasonable for reimbursement. And if they cannot do that, they go to arbitration. Arbitration is the perfect tool for this situation because although it's not free, it's cost effective and requires that the arbitration operate within the customary and reasonable expense range when reimbursing. I expect what you're going to hear is opposition, people contending, and what I heard anyway, is that networks do a good job of lowering healthcare costs. How's that going for you? You'll hear that providers, they're concerned that providers will gouge, taking advantage of the arbitration process. Well, it's $300 to arbitrate a bill. That $300 difference eats up a lot of that difference in what may or may not get covered. So I consider that negligible or a non-issue also. And that the consumers in general prefer tight network situations. Well, what people want is they want lower premium. But I haven't talked to one single person that wants an insurance company to determine what the doctor does to that patient. And so I ask for everyone's support on this amendment.
All right, questions for the Representative Lunan and the 824 amendment? Representative Halverson.
Thank you, Mr. Chair and Representative Lunan. I want to raise a couple of concerns. One is surprise billing happens. It happens to consumers, and it's a big deal when it happens in emergency situations. We often have conversations in this committee and in the legislature in general about putting the consumer in charge and letting the consumer make all kinds of decisions. Emergency situations, it's very hard to be the driver of decision-making. And you might be on vacation, you might not be conscious. There's all kinds of reasons why you don't get a lot of choice with regard to where you get emergency services. And the fact is that these providers are not supposed to be balanced billing consumers for the emergency services that they're being paid for. But it's happening. And when it happens to consumers, it's very, it's a shock. I mean, I've talked to folks who have gotten a $100,000 bill that they weren't expecting with regard to emergency services that they've received and have had to fight hard to be held harmless in those situations. And those are the folks who know to call their legislator. And those are the folks who know to call their plans. And those are the folks who know to fight the bill. I can't imagine how many people are out there trying to, whittle away a bill worth thousands of dollars that they don't even know they're not responsible for. It's pretty unfair. So I do completely agree we had to address the issue of surprise billing in emergency situations. I did introduce a bill earlier this year to do just that. I do want to say Representative Lunan wants this bill to do way more. I hear that Representative Lunan wants this bill to get rid of networks and do all kinds of other things with regard to health care. That we really can't deal with. And I think that the fact that we haven't heard this bill is, as a bill is extremely concerning. I also think that we need to perhaps hear from some of the stakeholders in this discussion with regard to balance billing. I would wonder if anybody is here from the plans who might be willing to talk about how this binding arbitration would play out, because I have a lot of concern about the cost with that, particularly when the balance billing isn't supposed to be happening in the first place. So could we hear from somebody about that?
I see Ms. Commit coming forward. Mr. Yulin, Ms. Commit, welcome to the committee.
Thank you, Mr. Chairman and members of the committee. I'm Catherine Commit from the Minnesota Council of Health Plans. And thank you, Representative Halverson, for your question. You are correct, and you'll see in the amendment, in the first section of the amendment, the existing language in subdivision 5 already says that the health plan company cannot impose any cost sharing restrictions or any changes or limitations that are more restrictive than already apply under a traditional emergency service kind of situation. So if you have a copay for $50 and you're seen in an out-of-network emergency room, you still will only have to pay that $50, as opposed to if you had chosen to go, or if it were not an emergency situation. The health plans, under a prudent layperson standard, both in state and federal law, are already required to hold the patient harmless financially. The patient is only subject to the same cost sharing. And I just want to set some context. This does not happen very often, but when it does, the health plan does work to protect the patient and hold him or her harmless, and works directly with the out-of-network provider to resolve the surprise bill. The real problem here is that out-of-network providers who take advantage of patients having a medical emergency and subsequently send them a separate bill to the patient, and that's why it's called surprise billing. It's frightening and concerning for patients. As I stated earlier, health plans already negotiate with the out-of-network providers, and what I'd like to do is ask my colleague Joel Yulin to talk specifically about a couple of situations that UCare has experienced.
Mr. Yulin.
Mr. Chair, members of the committee, my name is Joel Yulin. I'm the Associate Vice President for Public Affairs at UCare. UCare is a health plan that is currently serving about 400,000 members. Of that number, about 30,000 of those members are in the individual market. Just to add a little context to this is that we have had, of the 30,000 members that we're serving in the individual market, we've had about a dozen cases just in the last year or so of situations where people are experiencing some very significant surprise bills. We've had a number of them that have been in the $30,000 to $40,000 range, and we've had a couple that have been in the six-figure range. I think that we support the concept of trying to address surprise billing. This is certainly been a concern of ours. I think what we were looking at is just trying to figure out what's the best way to go about it. I think the concern that we have with arbitration and going through that is that we don't know what kind of incentives that will create. Will have down the road impacts that we have not fully foreseen yet. One of the proposals that we've been looking at is there a way in which you could take, for example, a Medicare rate, which is a known rate both to the plans and also to providers, as a way to to try to address this concern. So that way, there is just, the providers are getting paid, and we are paying an out-of-network rate. It isn't like we're not paying anything toward the providers, but it's a way to try to make sure that we're balancing the needs, but also protecting the members in the same vein. So with that, I'd answer any questions. Thank you.
Representative Halverson.
Thank you, Mr. Chair. So 2 questions I have for you. So based on existing statutes, I'm curious of why consumers are continuing to get the bill. And I'm heartened to know that it's not particularly common, but I can't even imagine what it would feel like to get a $30,000 bill that I wasn't expecting. And honestly, you don't know. I mean, I remember when my kid was in the hospital and talking to my husband and being like, what's it going to look like when we come out the other side, right? We didn't know. We couldn't plan financially for what was going to happen after our son got discharged from the hospital because we had no idea. We're very lucky, but the fact is you're pretty vulnerable in this situation when you're trying to get care. And so why do folks get the balance bill now? And I seem to recall a few years ago that there was some work that the Attorney General was doing with regard to out-of-network billing and surprise billing. And I might be remembering it wrong, but I feel like we've had this conversation before. We've gone down this road before. So to me, it's like it's a problem that continues to crop up, and we clearly haven't done the right thing to fix it yet. So thank you.
Mr. Chairman and Representative Halverson, I think with respect to the situation you're describing where the Attorney General is involved, you may want somebody from the Hospital Association to speak to that, but I think that had to do with bill collecting. But
if it's off topic, I'm sorry, but
yeah, they should be the ones to speak on that. Just to reiterate what my colleague said, having to go to arbitration risks having to pay the provider more than the amount than what we would maybe be able to negotiate, a lower amount. Because we're not in, it's just more difficult in a arbitration situation, and that will incent providers to always seek arbitration and not negotiate with health plans. And we establish provider networks in order to get volume discounts for patients and have lower rates. So I agree with Representative Lunin, healthcare costs too much, and putting this requirement on the health plans will make it just sort of chip away at those tools to be able to control costs.
Representative Halverson.
Sorry, Mr. Chair. I just have wanted to get a little bit more clarity in where the hiccup is happening with regard to folks aren't supposed to be balance billed in the first place. Is that, am I reading this correctly, or is there enough of a loophole that people can be balance billed? Or
Mr. Chair and Representative Halverson, the problem is that the requirement is on the health plan. So it's drafted to Chapter 62Q, which is it covers health plans. It's not drafted to oversee the actual provider entity who is billing. So the onus is to enforce it through the health plan, and the health plan tries to do that, but sometimes providers will balance bill anyway. Plus, it may be an out-of-state provider, and they're not then subject to the state law. So it's even more difficult.
Representative Lunin.
Thank you, Mr. Chairman. And to Representative Halverson's first comment, I do have a frustration in the area of networks in that all of a sudden an insurance loss is no longer between the insured and the carrier. It's between the carrier and the provider, and the insured's out of it. I would like to create an atmosphere where people take more responsibility for their health and their health care and doing that. But you misspoke when you said I wanted to do that with this bill. That isn't what this bill does at all. To her comment about that, I've heard this before and maybe I remember it wrong. That's because last year we on this to get rid of the surprise billing, which I agree to is It's got to be devastating to someone who already has a potential work loss situation, health concerns and all that, and all of a sudden you get dropped on this big bill. Last year, we passed this, and the arbitration process and mechanics was agreed to and was passed in this body by 90% of the legislators. So we've done this in the non-emergency field, and that's where the arbitration came from. As far as the comment about a concern about arbitration forcing us to pay more, if you look at lines 1.23, I'm doing that without my glasses on, the arbitrator has to consider 62Q.556, which incorporates in their decision reasonable customary charges. So it isn't a wild, wild west. It does bring it within a certain tolerance, if you will, on that. I still contend this is a good amendment.
Representative Hamilton.
Thank you, Mr. Chairman. And first of all, I want to just share with you what took place. Very good friends of ours were in Arizona, and she was hiking in the hills with her daughter, and she stepped wrong and shattered her ankle. They had to bring in a helicopter to get her out of there, and then she had to wait until she got back to Minnesota in order to get it set and fixed. And I asked, did the insurance company pay for it? And she said, not without a fight. They had a $17,000 bill. And she said they had to fight in order for insurance to pick that up. So my question back to the author of the amendment is, would this address that situation to where the bill would not have gone to, in this case, friends of ours in Mountain Lake?
Representative Lunan.
Thank you for the question, Representative Hamilton. What the bill would, the amendment would do is force both the provider and the carrier to the table to decide what the reimbursement rate should be. So the person that you know should be out of that part. They have coverage for that. They decide it. What that decision, if those two can't work it out, then they go to arbitration, and different third party then would decide it. But the answer to your question is yes. And Representative Halverson made a good point. Surprise billing or balanced billing isn't supposed to be going on, and it is a very traumatic thing for those that have it happen. And people that travel, that have these different situations, they are the most typical ones at risk.
And Mr. Chairman,
Representative Hamilton.
could I ask MMA just to come down and weigh in on this? That would be okay?
Welcome to the committee, Mr. Renner.
Mr. Chair, members, Dave Renner with the Minnesota Medical Association. If I can just get my amendment. Mr. Chair, we have concerns with this amendment as well. We've talked with Representative Lunan. Our concerns are probably different than the plans. First of all, I would say that if you recall, just last year, you all did pass legislation prohibiting what is called surprise billing, and you intentionally applied it only to non-emergency services. I would argue there's two reasons you did that. Number one is the language that's in the amendment under subdivision 5, which clearly says, I as a consumer am protected. I cannot be charged more than my cost sharing than I would be if I were in network. So I think the legislature looked at that and said, it's not as big of a problem. I can't answer how often it happens because I don't think a lot of the surprise billing concerns that we have heard have not been in the emergency room. Now, what you passed last year just became effective January 1 of this year. So again, it's taken a while to get going. The second reason I believe that the legislature chose not to apply it to emergency is because of EMTALA, emergency rooms, emergency providers are required to take all takers as well. Whenever you get into the discussion of trying to arbitrate or decide by legislature what payment rates should or shouldn't be, as you heard from the plans, they're fearful that we will use this to up rates. I would argue our members would say it's the opposite is the problem, is that most of our members, many times we hear from our members, they're not invited to the party. They're not invited to be a part of the network. And one of the reasons, so the plans, if this were to pass, there's potential that there would be less incentive to invite more members into the network. So I understand the concern. I cannot defend those who may be doing this. I don't know why they would be doing this because I clearly read the current language that says if I am going to an emergency room out of network, I cannot be charged more than I would be charged if I were in network. So I would argue that this language, the first part of this amendment is not needed. I think the second part of the amendment gets into the whole different issue of then what should the payment rate should be, and that's something I would caution you to be very careful about.
Thank you, Mr. Renner. Further discussion, Representative Liebling.
So, thank you, Mr. Chair. I wanted to ask Ms. Commit another question, because if she would come back, I don't think she explained why this is still happening. And Representative Lunan, the more I hear about this, the more I like your amendment.
Well, don't make it sound like it hurts.
The language that Ms. Commit pointed to would seem to preclude the patient from having this problem, and yet it isn't precluding it. Going back to, I think Representative Halverson was asking it, and I didn't really hear an answer. Since the law seems to preclude this from happening, or at least, now maybe it doesn't protect the patient from getting an initial bill, but it certainly seems to say that it has to be covered by their insurance company. And yet, that doesn't seem to be happening. Or is it that it will happen, except the person has to know and go and fight and, so could you please just explain that? If the law clearly prohibits it, why is it still happening to people?
Ms. Commit.
Mr. Chairman and Representative Liebling, because providers they can send a bill, and they do that sometimes. And when we find out about that, we turn around and get in touch with that provider and attempt to negotiate with the provider. We're paying the provider for the services. We are reimbursing them typically at whatever, either the in-network rate or maybe something a bit higher. I don't know what the rates are. But a provider can just turn around and say, that I don't care, I want to bill the rack rate. And it's particularly difficult for when you're dealing with out-of-state providers. That said, we hold the enrollee harmless, but then somebody is on the hook for that extra bill. And it can be, we attempt to negotiate and work it out. But under this amendment, we would have to go to arbitration.
So, Mr. Chair, so if I'm understanding, so the enrollee is supposed to be held harmless. I think what the people who are sitting here are worried about is what happens to that enrollee, what happens to the person who gets sent this bill. The issue about what happens then between the plan and the provider, while it's important, is kind of a different issue. And but for some reason, the enrollees are still getting that bill, and some of them are under the impression that they then have to pay it. And obviously, the law doesn't require them to pay it. So, that's the problem. And I don't know, I mean, something is wrong, notwithstanding that the law appears to say that they don't have to, that they only have to pay the same out-of-pocket that they would pay if it was in-network. They're still being asked to pay more, and I hear you, it's the provider who's sending them that bill. But maybe the plans need to be telling people, if you get a bill for emergency services, send it to us. And, that's what's frustrating about this.
And Mr. Chair and Representative Liebling, I share your frustration. It's hard for us to enforce this against providers, so maybe that's an area that the legislature wants to look at, is an enforcement mechanism for providers.
Thank you, Mr. Chair. So 2 points. One, I think that the health plans, if you don't already do this, should notify their enrollees that they don't have to pay if they're billed by the provider. I don't know if you do that. And then 2, in the last year, I've received so many complaints and concerns from my provider groups in my district that they're having a difficult time negotiating adequate reimbursement rates with the health plans. So if we see an increase in balance billing from providers, I'm wondering whether it's because they're not getting adequate, some of them are not getting adequately reimbursed and not having fair negotiations with the health plans.
Well, Mr. Chair and Representative Schultz, I think everybody around the table wants the health plans to negotiate really hard on behalf of their members, to negotiate the very lowest possible rates possible. And one tool in our toolbox, one remaining tool in our toolbox is to be able to develop provider networks that are in exchange for volume of patients going to these providers, they will offer lower rates. And I'm going to turn over to Joel, who has
And Mr. Chair and members of the committee, I mean, also to your point, it is in our member notices that we send out. And I think that one of the things that's very frustrating for us is that we don't, as a health plan, we often don't find out that our members are being balance billed until months after the fact. And often it comes in the form of an attorney general's complaint to us or some other form of a complaint or a legislator complaint. And so, you know, for us, we don't hear about these things until way after it has already been well into the process.
I just have one more point, Mr. Chair.
Representative Schultz.
So it's interesting that you're telling me and us that you get volume discounts from reimbursement rates, but it's the larger providers that get higher reimbursement rates that I'm aware of, and the smaller care systems or clinics get lower reimbursement rates. So I don't know if I would phrase it as a volume discount. They're getting reimbursed more.
Representative Loeffler.
Well, thank you, Mr. Chair, and I think we're all struggling to kind of understand the situation, but is this my understanding? The health plans have negotiated rates with the people in their network. So situation A comes along and they'll pay for a particular emergency procedure $10,000. And their provision is that the copay of, let's not ignore the deductibles, but the copay is 10%. So the enrollee would be on the hook for $1,000 if it was in network. But the emergency happens outside the network. They cannot safely be traveled to a network provider. So this provider, say it's a hospital, charges $12,000. And so the insurance company says, well, we pay $9,000 typically, so we'll give you $9,000. The enrollee has said you'd have a copay if it happened in network, out network, instead of being charged the $1,000 that they would be paid if it was an in-network, the 10% of the agreed upon charge. They're instead paying 10% of $12,000. Or is it that they're asked to pay the full $3,000? Just so we kind of get a sense of even does the percentage for out-of-network apply to the consumer's benefit, or are they totally at the mercy of whatever that provider decides is a reasonable charge?
Mr. Chairman and Representative Loeffler, first of all, most ER visits typically have a $50 copay. So I want to disabuse everybody of the notion that somebody's going to be paying 10% of an emergency room visit. What I will say is that, again, the law already requires us to treat the patient's cost sharing exactly the same way had they been seen by a in-network provider, even if they're seen by an out-of-network provider for an emergency room service.
Well, Mr. Chair, I think that what we're trying to solve is not the $50 visit to reassure yourself. It's the really serious visit that we're hearing people have $10,000 to $30,000 or more of cost sharing imposed on them. And we had, and I don't know that we put it in law, I think there was kind of an agreement, as I recall, that, for example, hospitals would charge the uninsured their lowest discount rate. So because it used to be people with no insurance paid the highest rates of anybody. And, maybe that's another avenue for us to look at so that they get the discounts that particular provider offers to anyone in the insurance industry. And one would assume that would be a more typical kind of form of cost sharing. But I do think this is a real problem, and it's not the $50, see if that temperature is an issue or whatever. It's the serious problems where you're in a car accident or something really serious happens and you require sophisticated treatment. And it's hard at this point in the process to problem solve, but maybe by putting this in the bill, we'd keep the discussion going.
Thank you, Representative Loeffler. All those in favor of adoption of the A24 amendment, please say aye.
Aye.
Those opposed, no.
No.
The A24 is adopted. All right. Representative Halverson.
I would like to request perhaps we consider the A50 amendment because it's the same topic. And since everybody's very busy learning about surprise billing, it might be helpful to have the conversation all at once. It's your decision, of course.
1-5.
5-0, I said 5-0, yeah.
Representative Halverson will move the A50 amendment. However, because we've adopted Representative Lunen's amendment, it will be out of order, but welcome the discussion, Representative Halverson, to the A50.
Thank you, Mr. Chair, and if I may move that we divide the amendment, and then it would be in order if we divided it and just dealt with the pieces after line 5.9.
Representative Halverson, I think we moved the A50, you moved it already? All right, Representative Halverson. Representative Halverson moves that a division of the amendment between lines 5.9 and 5.10. Discussion of whether or not this will work.
I'm sorry, I grabbed the wrong line. Which line was it again? 120, after line 120,
Yeah.
or after line 119.
Yeah.
Yeah, and then everything else afterwards would be part of that.
So Representative Halverson moves a division between lines 1.19 and 1.20. That would be before section 3. And which would you like to vote on first, Representative Halverson?
The second half, Mr. Chair.
The second half first. All right, first, does staff have an opinion on the divisibility of the amendment? I'm looking at it right now, and if anybody does. Representative, or excuse me, Mr. Chun.
Mr. Chair and members, I think the division at that point would work because those are sections 3 and on are separate sections dealing with the board's powers.
All right, Representative Halverson.
Thank you, Mr. Chair, and sorry to add some complexity to this, but one of the things that we've been hearing through the testimony is that we have not found a way yet to ensure that medical providers are not doing the surprise billing. The expectation is that folks are not, but it's very clear that from testimony we heard from the MMA and from the health plans that it's hard to determine who is doing the balance billing and how it's happening. And if we made licensing dependent on being compliant with that law, it would put some teeth back into the law in terms of holding the consumer harmless. The fact that consumers are still getting these bills and that we're very often not finding out until months later is concerning. And so this would just put a little bit more teeth into the billing side and saying that these folks cannot be billed for the balance, as is the expectation currently.
All right, Representative Halverson, and once again, we are discussing the second portion of the division from 1.2 on, and Representative Lunen.
Thank you, Mr. Chairman. And I would speak against this amendment, this part of the amendment, in that this puts the legislature in the business of determining rates where it would be based on Medicare, and I don't think we want to be going down that line. As far as people still requesting or still getting balanced billing, the amendment, the A4 amendment that we passed, and it's on this amendment also, on line 1.12, we now, if this prevails, it is illegal for them to even send the bill. You can't even request the balance bill, let alone they don't owe it. If you send the bill, you're in violation. So I consider that addressed on the other part of it. The second part, what we're voting on right now, basically puts us in a situation where we will determine what you as a doctor collect, and I believe that that belongs in the private market. They negotiate it. They can go to arbitration if they can't come to an agreement. So I would request a no vote.
Mr. Chair.
Representative Halverson.
Thank you, Mr. Chair. Again, we're dealing with some really complex stuff that hasn't been heard in committee. I'm wondering if we could hear from some experts on this, the plans, I think would be helpful to hear from in terms of how this would change who's getting billed.
I see Ms. Commit coming forward. Welcome back to the committee, Ms. Commit.
Thank you, Mr. Chair. Mr. Chair and Representative Halverson, this simply makes a change in the section of statute that regulates by the Board of Medical Practice, regulates providers, and says that providers, if you engage in, this is existing statute, it says engage in abusive or fraudulent billing practices, violations of federal Medicare and Medicaid laws, or the state medical assistance laws, or, and then it adds this provision that you're not allowed to balance bill, then that could put your license in some jeopardy. So it simply is adding this requirement to the section of statute where providers are regulated by the Board of Medical Practice. It doesn't really have anything to do with the Medicare rates. That's not part of this amendment. I believe that what you're talking about.
Thank you, Ms. Commit. And that's the only, I think, Ms. Commit, the only change I can see in the portion of the bill that we're voting on is on line 8.14, adding the subdivision. So that's really all this is doing, is putting providers on the hook for another violation in threat of losing licensure. Is that correct?
Mr. Chair and members, it's in two places, actually. It's on line 5.10 and also on line 8.4. And I'm sorry, I'm not an expert in this section of statute. It's in 147 and 148. And I'm sorry, I do not know what, I know 147 is Board of Medical Practice. I don't know what 148 is, but maybe staff does.
Oh, I'm told that's the nurses.
And
Representative Halverson.
Mr. Chair, the purpose of this, and just to be clear with Representative Lunen's earlier comments, that we're not dealing at this point with anything having to do with rates. This is simply trying to get at the question that was being asked before, which is, why are people continuing to be billed? And people are continuing to be billed because there is nothing in law that is prohibiting balance billing from happening on the provider side. It is prohibited from the plan perspective, and there's more than one party in the billing in this billing situation, and because we don't have anything currently in statute that makes that requirement on the provider side. This is a way that we could do that and get more clarity and prevent the consumer from being billed, because that is the ultimate goal, is we don't want to see the consumers with surprise bill landing on their lap.
Representative Johnson.
Mr. Chair, Representative Lunan, Representative Halverson, I appreciate what you're doing, but I think we're going at it might be going at it the wrong place, because the surprise billing is not coming from the healthcare insurance providers, it's coming from the hospitals. I myself have been, on one day, received the bill for my visit and the collection notice from the collection agency for that same visit. We need to look at what the hospitals are doing, maybe regulate that area a little bit better to make sure they're doing their billing process properly.
Thank you, Representative Johnson. Representative Halverson, as I read this and kind of try to understand it a little bit better, if you're if you're a doctor in small-town Minnesota and your office puts out a bill to somebody and it's outside of that section, you're threatening a license for a billing issue? I mean, is that what this is trying to do?
Mr. Chair, the purpose of it is to try to have some type of regulation with regard to what the providers can do in terms of billing. The expectation is out there. There is nothing in statute that's doing anything to prevent this balance billing from happening. So it is some pretty, it is some definite teeth in the law. But the fact is we have folks who are, we're having a lot of trouble with the consumers, and we haven't gotten good feedback from the provider community on how to start how to stop this from happening. We have to do something more than just throw up our hands and say, sorry, they got that $30,000 bill, but nothing we can really do about it. Other than on the health plan side. That's where we regulate it in law right now, exclusively.
Representative Halverson, I think it does have a lot of teeth. I think it might be biting the wrong person in many cases, and we're having a hard time getting providers to many portions of the state, and I think that I really appreciate what you're trying to do with it. But we've got such volatile markets particularly in greater Minnesota with the collision of networks and consolidation that I really see a potentially damaging downside for rural providers that are trying to keep their shingle up and serve patients. Representative Lunan.
Thank you, and I just want to apologize to Representative Halverson on my pages for my former protest. I try to wear my hearing aids when I listen. Now I know I need to wear my glasses when I talk. Because I put my mark on the wrong spot on the bill. So this part of the bill, I remove my opposition to.
Mr. Chair.
Representative Halverson.
Thank you. I think that, as I actually felt with Representative Lunan's amendment, that this is something that probably needs a lot more conversation. I think that we have done a very good job of identifying the problem and identifying who we want to protect and hold harmless. But I would like to withdraw the amendment at this time and make sure that we continue to work on it as a body and make sure that we hold consumers harmless.
All right. Representative Halverson withdraws the amendment. Representative Halverson, I appreciate the work and the intention on the amendment. We will continue that. Representative Zerwas is withdrawing the A26 amendment. Representative Lunan has the A27 amendment. Representative Lunan to the A27.
The 827 amendment, Mr. Chairman, has to do with foster facilities and license moratoriums on what can happen and as far as rulemaking and some of the issues with these foster situations is the round-the-clock nature of it, and the night supervision, and making sure that we're creating good situations for the children that we're putting into these facilities or into these situations.
All right. Discussion to the A27 amendment. Representative Liebling.
Well, thanks, Mr. Chair. I just wonder if there's anybody in the audience who would want to testify. Representative Lunan, is this something that was this a bill that we heard?
Yes, Mr. Chairman. Yes, Representative, we did hear this bill.
Representative Liebling, this was the ARM bill, and I think we might have somebody that would be able to answer any questions about changes or how the bill moved through the process. Refresh us if you'd like.
Thank you.
Welcome to the committee.
Thank you, Mr. Chair and committee members. So this bill was heard in both the House and the Senate. There were some differences. So what you're seeing here is the House language, and we are attempting to get it incorporated so it actually moves through and gets passed as part of this bill because it was moved to the floor, or moved to be heard on the floor. But in case that doesn't happen, there's some really important things, and we're hoping it can move here. And I can speak to any of the parts if you want me to.
All right. All right, all those in favor of adoption of the A27 amendment, please say aye.
Aye.
Opposed, no. The A27 is adopted. Representative Albright moves the A30-1 amendment. Representative Albright, your amendment.
Thank you, Mr. Chair. Members, this bill pertains to NEMT transportation. The commission thinks very closely about the effects that it has on the cohorts to the commission. This was vetted in commission on a couple of occasions, and I have spoken with all of the stakeholders to it, and they are approving of the amendment, so I urge your support.
All right, discussion to the A30-1 amendment. Representative Liebling.
Thank you, Mr. Chair, and thank you, Representative Albright. I don't know a lot about this advisory committee, except that it's been really controversial sometimes in the past. And I just wonder, I don't know if I missed this, if you said it, but was this a bill, and who else has vetted this aside from the people that are on this committee now?
Mr. Chair.
Representative Albright.
Representative Liebling, thank you for that. The commission, as you have expressed, can be fairly contentious from time to time, but well-meaning nonetheless. This was heard in the commission. I don't recall it coming forward to a bill in reform. It was heard in bill form in the commission's possession, but I'm sure that if representatives from NAMI or from the the Ambulance Association would be willing to speak to it, I'm sure that would be fine. I know that DHS has also weighed in on and is comfortable with the language as well.
Okay, thank you.
I see Ms. Abderholden here. Welcome to the committee.
Thank you, Mr. Chairman, members. Sue Abderholden, Executive Director of NAMI Minnesota, but also longtime chair of the Non-Emergency Medical Transportation Committee. And you're right, it has been a contentious committee many times in the past, although we're getting along very well right now. We did look at this piece of legislation. There was one tweak that needed to be made to it, which is reflected in the amendment, and everyone is fine with it.
Thank you.
Thank you, Ms. Abderholden. Is there any other discussion? Seeing no other discussion, all those in favor of adoption of the A30-1 amendment, please say aye. Aye. Opposed, no. The A30-1 is adopted. The next bill up, or amendment up that we have is the A33 amendment. Representative Lomer moves the A33 amendment. Representative Lomer, to your amendment.
Thank you, Mr. Chair and members. So Minnesota has long had a preventive services coverage requirement in statute, which includes mammograms. This is Representative Peterson's bill. So this amendment amends that section to clarify that preventive services includes 3D mammograms, formerly known as digital breast tomosynthesis, I'm not saying that right, for women at risk for breast cancer. At risk of breast cancer means having a family history, a BRCA1, a BRCA2, dense breast tissue, or a previous diagnosis of breast cancer. So the cost difference between a 2D and a 3D mammogram can range from under $100 to around $150. While it is slightly more expensive, the benefits could ultimately save policyholders money through early detection and reduced false positives. So because CGIP expects increased utilization of 3D mammography, and the amendment asks CGIP to submit written testimony to the HHS and state government finance committees on the actual utilization experience for the first 6 months in which this amendment is effective, we don't want to mandate a big report. We just want to make sure the committee keeps up with what happens if this language becomes law. So thank you for your consideration.
All right, discussion to the A33 amendment, Representative Liebling.
So, members, I'm not speaking for or against the amendment as such, but I just want to really flag for all of you an issue, since Representative Huntley is no longer here to be our sort of historian on this, but over the years, when the legislature has weighed into sort of scientific issues and mandated that insurance companies cover stuff, sometimes we get it wrong. And in this area of screenings for different health issues, especially breast cancer screening, the scientific issues are actually a lot more complex than one might imagine. And in this particular case, I actually feel a bit more comfortable with it than I might in some others. So I'm not speaking against this, but I'm just putting out a word of caution here. You know, we have this insurance system. I mean, this is sort of a rare occasion when I'm kind of speaking on behalf of the insurance companies. Don't hold me to that in any other context, but, you know, we're deciding for them here. When anything that comes to the legislature, where it's being decided by us, we're injecting politics into it. And so when we make these decisions about what insurance companies should cover or not cover, we're really injecting politics, you know, how popular the thing is, and so on, into some questions that can be pretty close questions sometimes, and can involve not only, you know, is something a better treatment or a better test than something else, but also, you know, what the cost-benefit analysis of that might be. So, I just wanted to not let this go by without, you know, I'm not going to vote against it. I'm not asking you to vote against it, but there's sort of a politics of breast cancer. You know, there are groups that get behind these things, and sometimes these issues take on a life of their own, whether the science is there or not. So I just kind of wanted to flag that for people. A few years ago, we passed into law, when I was chairing the Reform Committee, or the Policy Committee, we passed a requirement that women be given certain information about having dense breast tissue, okay? And it was watered down somewhat from what other states were doing because of some objections that I had to it. And the further science has made it more and more murky about whether having dense breast tissue is actually, you know, what the meaning of that is for people's health. There's even recent scientific papers about the very definition of what that is differs between different physicians and so on. So I just wanted to take the opportunity to make those comments to kind of raise this on people's radar for the future as we move forward with this.
Fair enough, Representative Liebling, and I share some of your concern regarding the mandates that Minnesota puts on plans and others with what we say is mandated. And kind of what we did in this case, I think, is made a bad situation worse by, you know, telling women that, you know, when you get a screening that, you have dense breast tissue, you probably do well with a 3D mammogram, but we can't pay for it. So you just made a stressful situation for somebody very much more stressful. So this, I think, is an attempt to alleviate some of that, but I think you bring up a valid point in many of the mandates that we put forward. So fair enough, Representative Liebling. All those in favor of adoption of the 833 amendment, please say aye.
Aye.
Those opposed, no. 833 is adopted. We are going to be coming back to this room at approximately 5 p.m. Members can leave packets on the table. We will have a page in the room, so if lobbyists want to stay in the room or come back, that's perfectly fine. And we will come back for the remaining amendments at 5 o'clock or at the call of the chair, so watch email for an update if it's different from that. With that, we are in recess.